if you can try put it on. Yep. Yes. It's
Okay, no problem?
Yes.
Okay. So we'll try and run this, like I said, more like a question answer, more like a tutorial session, right?
Yep.
So as a rough outline, I'll just cover under three broad headings. The first one is what is this post-genomic era? And then secondly, we'll talk more in relation to the complexity that we are facing in this post-genomic era, and how as public health specialists, we should then transform ourselves to be able to deal with this complexity. So I call it as from public health 1.0 to public health version 3.0, right? So I'll cover this under these three broad outlines. So maybe to kick off as a discussion, we start off by talking about first the Human Genome Project. You can say that that is kind of like the start of the genomic era, and that after the Human Genome Project has completed, we are now within the post-genomic era. So anyone want to start off by describing what the Human Genome Project is? Vincent.
Okay. I think first of all, Human Genome Project.
Can you hear Vincent?
Yes, but can you go a bit slow because there's some kind of voice echoing if you go fast.
Okay.
Yes.
Okay, Vincent.
Okay, I'll try again. So, I mean, the Human Genome Project is actually run by actually the Department of Energy from United States. So, it's actually formally started in 1990 with National Institute of Health. So, the ultimate aim of the Human Genome Project is to try to understand what makes up the whole genome in the human cell. So the objective is to identify, if not all, most of the proteins or the genes actually that is found in the human cells. And that is with the hope that we can actually make use of all this information to help to revolutionize how we think about how we can treat diseases, diagnose diseases, or even give a better understanding of how the mechanism of disease actually works. So besides that, it's also used to actually help us to understand more about how we can actually develop tools, modeling tools to understand the changes in terms of human evolution.
Okay. Brunei side, can you hear what has been described?
Yes.
But feel free to comment if you have any other thoughts.
Anyone from your side want to add on to what the Human Genome Project was all about?
Anybody want to say something? Huh? What is it? Can you give example?
Mapping of the human genes, basically.
Sorry?
Basically, it's just a mapping of the human genes.
Okay.
I know it started, I think it's in either 2000 or more, but it's expected to complete by 2005, but they completed it later here in 2003. And what the codons are after basically sums it up everything.
Can you hear that? What's your name? Hamiza, can you hear Hamiza?
Not very clearly.
Would you like to share any more? Basically, she was saying that they had started back in
2001.
2001?
In year 2000 or 2001, I'm not sure.
And yes.
But it's completed way before the deadline.
Okay, flipping of genes. Basically, she was saying a study that has been done. Yes.
Hello, are you still there?
Yes, we are still here. Carry on.
what is actually the end product of the Human Genome Project? At the end of this project, what was the first product that was available? Rick, you're the expert.
We have the human genome sequences in terms of the DNA coding of A, C, G, and T for about 3 billion of bases.
Okay, so one way of looking at the Human Genome Project is that it is actually a series of projects. The first project was actually trying to map out every single base of the human chromosome. So all the 23 pairs of DNA, you can conceptually look at it as starting from base number 1 of chromosome number 1 all the way to the last base of chromosome 23. That we roughly know what is the sequence of all these bases, right? And what is quite interesting is at the end of it is that we think that on the average we have about 3 billion bases. But out of these 3 billion bases, we are 99.9% identical. So whether you're Chinese, Malay, Indian, Caucasian, we are about 99.9% identical. Right? So the difference is only actually at 0.1% level.
All staff and students to Church of Singapore will be arriving soon. All staff and students are encouraged to go down the second courtyard to give a warm welcome to the students. Thank you for your time.
Sorry, it's just an announcement from our side. Sorry, Prof.
Okay, no problem.
Yeah.
But 0.1% of 3 billion is about 30 million. So there's actually still a lot of differences. So based on the 30 million, you can actually tell quite a lot of differences in different ethnic groups. So say for example in Singapore, we managed to see the genetic differences between Chinese, Malay and Indian population, right? Based on studying the differences among those 30 million bases. Now some of these differences are rather rare, and there will be about 10 million whereby the frequency is more than 1%. Right? So there are about 10 million differences that are quite common in terms of occurrence. So we use the term single nucleotide polymorphism or SNP for these more common differences among the bases. Right? And the idea is that we are then able to use this as potentially markers of genes and see whether are there any differences between those with diseases and those without diseases. So that is what basically a genome-wide association study, or GWAS, is all about. Theoretically, I can look at all these 10 million differences among those with diseases and those without diseases, right? But to do 10 million SNPs, that is quite costly as well as computationally quite intensive. So what has made GWAS study possible is firstly the cost of genotyping has come down tremendously. Now it's less than 1 cent per SNP that you are analyzing. And secondly is that out of these 10 million SNPs, we can find that about 500,000 to 1 million are what we call tagging SNPs. In other words, with this 500,000 to 1 million SNPs, we can roughly know already the information about these 10 million things. So that's what a genome-wide association studies have been done over the last 1 decade, last 10 years. We have a lot of genome-wide association studies. But what's the aim of doing this GWAS? Why are we doing GWAS, and what kind of diseases are we doing GWAS for? Anyone? Sorry?
Pretty much all diseases we can find.
Yeah, but what kind of diseases were the focus? Yes, so it's more the common diseases, right? So the idea was that can we find the genetic basis of common diseases? Right? In the past, the way we look at diseases is we classify diseases as genetic diseases and non-genetic diseases. That's what I learned at least when I was in medical school. And genetic diseases are really diseases that have a very, very strong genetic basis. So like say sickle cell anemia, thalassemia, hemophilia, where we can actually find the gene that is causing the disease. And it runs in a family, in a very strong way, right? Whereas a lot of other diseases, like say diabetes, hypertension, and so forth, although they do occur in families, but the reason they occur in family is mainly because it's such a common disease, right? But no genes to be found. Right? So using traditional methods, you cannot find a gene for all these common diseases like diabetes and hypertension. Right? But because of that tendency to occur around families, people still think that there's a strong genetic basis for it. Right? And they felt that the reason we can't find it is because we don't have the tools. Now with the Human Genome Project, whereby I can study individual bases, they think that, hey, now I have the tools to be able to identify the genetic basis of common diseases. I now can find the genetic basis for hypertension. I now can find the genetic basis for diabetes, for ischemic heart disease, for stroke, right? And once I find the genetic basis for all these diseases, I can predict who has a higher chance of developing those diseases, and therefore I can intervene. Okay? So that was the dream. That was the aim, right, of this Post-Human Genome Project. That we have been able to find the genetic basis of common diseases. Therefore, we will be able to prevent these diseases from occurring. Okay? Okay? And because I know the genetic basis, I may even be able to find out whether can these be potential drug targets. And therefore, it could stimulate the discovery of drugs as well. Okay. So it has been 10 years since we've been doing all these genome-wide association studies. Have there been any success stories? Can you name me one success story?
There was some cancer drug was there, some childhood lymphoma drug that was piloted, but I can't recall any other.
The symptom?
Was that identified post-GWAS, post-Human Genome Project?
No, Herceptin was before. Okay, I think we've got to differentiate between two things now. One is that the Human Genome Project was trying to find out the genetic basis of common diseases by looking at what we call the germline DNA. In other words, the DNA that we receive from our parents, right? So this the DNA that theoretically should not change throughout our whole life, right? So whether we have a disease or no disease, this germline DNA will not change. Okay, so theoretically that's what we believe. So this germline DNA would serve to predict whether or not I would have a higher genetic risk of developing a disease. Okay, so that's what the Human Genome Project is primarily about. The same technology to do the Human Genome Project can also be used to study, for example, mutations that happen when you develop a disease, right? Specifically cancer. So in cancer, you get what we call somatic mutation, right? So in other words, the tumor itself undergo mutation, right? So those are somatic mutations which I can use to try and identify what kind of drugs would be suitable for that particular mutation, right? So it's slightly different. Germline mutations are used to predict whether or not I get a disease. Somatic mutations can be used to try and identify what drug to be suitable and also be able to help me to prognosticate. In other words, after I've got a disease, will these mutations and therefore my drug response predict how long I will survive from this, from say for example this cancer, right? So there are two different groups. Right now we are focusing mainly on the germline mutations. In other words, mutations that will help me to describe the risk of getting a disease. Okay. Am I going too fast or too slow? Is the speed fine?
Yes.
Any questions or any points that you would like to raise over your side? Brunei?
Let me know before you come in.
None at the moment.
Okay, alright. So we have covered until the point of, there are lots of GWAS study to look for genetic risks for common diseases, right? And most of it has been quite disappointing in terms of the ability to use these genetic markers to predict diseases, right? To predict common diseases. So, what would be then the genetic basis for some of these common non-communicable disease? And let me just show you an example here. We have breast cancer. Now there are basically, you can basically say that there are two types of breast cancer. One type of breast cancer that is relatively rare, runs in family, and it occurs in very young women, right? And that is a very kind of pure genetic disease, if you want to put it that way. So the gene that is responsible for those kind of breast cancer is the BRCA1, BRCA2 gene, right? But it occurs in very isolated populations or very specific populations where there's a lot of inbreeding, and it occurs in families, in clusters, in large numbers in families. And it is not very common. So for example, in Singapore, the number of BRCA1, BRCA2, the related breast cancer is less than 1% of all the breast cancers that we have, right? So most of the other breast cancers I will call them the garden variety type of breast cancer, not due to BRCA1, not due to BRCA2. Right? But a lot of people still believe that there must be a strong genetic basis for this more common breast cancer. Right? And in this study, there was some time back already. At that time, they identified about 7 genetic markers, 7 SNPs. Right now, we have about 70 SNPs now. Right? At that stage, we have about only 7 SNPs. And using the 7 SNPs, they find that they are unable to add value to what we currently use in terms of prediction for breast cancer. So currently we'll be using things like, say for example, the age of menarche, the age at which the first live birth, family history of breast cancer, history of breast biopsy, so forth. And those could be used to predict breast cancer, and the genetic markers actually perform worse than these non-genetic markers. And even when you add in the genetic markers, it only improves it by, very insignificant amount. So generally, the feeling is that the genetic markers that have been identified so far does not add value to what we currently know. Right? And this has been the same story for many of the diseases, like breast cancer, diabetes, heart disease, even cholesterol level. The same conclusion. We have found many markers, but these markers do not add much value in terms of prediction. Okay? So that's still the general consensus. And what would be some reason for that? I think I'll ask those who are more with a genetic background, like Rick. What would be some reason why SNP hasn't been that useful so far?
One of the things is that the SNP that has been identified so far are probably not the causal variant itself, but rather surrogate, because that's what you have said just now. The Genome Association study actually studies it as genetic markers, right? So, being not the true causal variant, right, the effect on power to predict the risk of disease might be substantially attenuated. That's one reason. Of course, another reason would be that we have to actually also understand whether these findings are actually being replicated in different populations, the same associated disease. Because due to LD differences between human populations, the same state could have different allele frequencies in the different populations that could actually have a result on the disease risk effect.
Okay, so that was Rick. Rick has a genetic background, right? So you'll find that right now in this whole situation, you can almost say that there are 2 camps. Right? One camp will be people who still hold very strongly to the idea that there are actually strong genetic predictors for all these common diseases. It's just that our tools, although it's very much better than the past, are still not good enough. Right? So we still need to try and find new tools or new ways to try and identify the genes that are responsible for common diseases. Right? So that's one school of thought, and they will come up with suggestions that SNPs are not very good markers, right? Maybe better markers would be things like what is called copy number variation, and other structural problems within the chromosome that would cause the actual disease, right? So that's one group. Another way of looking at it is that there are actually no such genes, right? And these common diseases are not due to genes. They are not due to non-genetic factors. So that's another school of thought, right? And so we say that these are due to so-called lifestyle factors, environmental factors, nothing to do with the genes. Okay? So you have these two camps, right? In a sense, fighting with each other and trying to claim that I'm right, you're wrong, or you're right, I'm wrong, and so forth. But being public health people, we are peace-loving people. Yeah. So we think that actually what is most important is actually that a lot of all these diseases have both roles, right? The genes play a role, the non-genetic factors play a role, and it is not quite correct to take the stand of saying that one is more important than the other, right? In fact, it is the interaction that is the most important. In other words, we should not be looking at causes of diseases from saying it's either due to genes or due to environment, and even if it's due to both, one of them has to be more important. Right? We should be looking at the whole causation of diseases from the angle of the two factors must act together. Right? If the two factors don't act together, you may not get such high frequency of diseases. Okay? So that's the whole idea of gene-environment interaction. And a lot of times we say that is just a conceptual framework, something that we researchers try to come up with and say that, conceptually it sounds very nice. There don't seem to be a strong biological basis for that. Right? What is interesting is last month there's this group. So this is also to highlight that the fact that even come out in the popular press like the New York Times to say that genes are of limited value, and that adds on to the tension between people who say genetic factors are more important versus non-genetic factors are more important. But I'm proposing that what we should have a different way of looking at causes of diseases. It is how both must act together before you can have a disease, right? Before you can have all these common diseases. And the biological basis for that actually came up possibly just a couple of weeks ago. There is this consortium called ENCODE. It's an encyclopedia of DNA elements, and they basically published 30 papers about last month simultaneously. And one of the main findings is something called junk DNA. Right? Junk DNA are what we saw in the past as these are regions in the DNA whereby there are no genes. And we thought they probably have no function at all, right? What this consortium has found is that actually within this junk DNA, there are actually a lot of control elements. It is actually very complex network, complex switches that actually switches genes on, switches genes off. And what's more interesting is that these switches interact with both genetic, but more importantly also non-genetic factors. Right? In other words, the non-genetic factors comes in to turn and turn off a switch to the switch. right? So I think this is one of the strongest evidence that there is a biological basis for what we commonly want to call gene-environment interaction. Right? That this gene-environment, this hunt for genetic basis for disease was actually very was actually quite futile in a sense, you know. And what we should be doing is to try and look at it from a more complex angle. That it is not just simply finding genetic basis for disease or non-genetic basis for diseases, but how these two actually interact together. Okay? So the whole idea right now is that what we thought was originally very simple turns out to be very complex. Right? We were hoping to, with the Human Genome Project, to open up the box and find very neatly, you know, in the box, the genes lighting up, right, for different diseases, and say, wow, I found this genetic basis for common diseases. But now the conclusion is, I've opened up this box and I see a mess of wires, a mess of switches. I don't really know what happens if I turn that switch off. I don't really know what happens if I cut that wire off, right? It is just so complex. You know, I can't decipher at this point in time. All I know is that the genetic basis is very complex and it interacts with non-genetic cells. Okay? So that's the conclusion up to this point in time in terms of the Human Genome Project. Okay, before I go on, are there any questions or any points that anyone want to raise? From Brunei, any questions or any points you want to raise before we go on?
Any question, guys? No, not at the moment. Carry on. Question? No? No, Prof. Carry on.
Okay.
Stay quiet.
Right, so let's talk about this idea of complexity. You know, I mean, so my first premise that I'm trying to make is that after the Human Genome Project, after the genomic era, we kind of acknowledge that things are very complex. So one of the way of looking at complexity is this concept of multifactorial diseases. Right? And in epidemiology, we always talk about this term multifactorial diseases.
What is your understanding of a multifactorial disease? How will you define a multifactorial disease? Now I can ask a non-geneticist here. Cancer. Why do you think cancer is a multifactorial disease?
Some types of cancers are associated with lifestyle. Some clearly have a genetic reason.
Okay, so you're saying that most cancer has a genetic basis as well as a lifestyle factor. So in that sense, they are multifactorial. Yes, that's one way of looking at it. Anyone else has any other example or any other view about what a multifactorial disease is?
I think all the non-communicable diseases are the multifactorial disease.
Sorry, I can't quite hear you.
Yeah, I think all of the disease are the multifactorial because of the effect of multifactorial causation effect that lead to the disease condition.
Hello?
Can you hear? Can you hear, Prof?
Yes, I can hear. Yeah. Yeah, so a lot of the non-communicable diseases are considered multifactorial disease because we say that there are many risk factors associated with that particular condition. Can someone give me an example of one that is Say ischemic heart diseases. What are the risk factors for ischemic heart disease? Right, your diet. What else?
Lack of exercise.
Family history. Yes.
Lack of exercise.
Lack of exercise. Good.
High cholesterol.
Yes, high cholesterol level, and that can be diet or that can be genetic, and also related to lack of exercise. What about this? What am I doing? Smoking. Right? So smoking is also another. So each of all these factors contribute to the risk factor for ischemic heart disease. So most of the NCDs we could say very easily that these are multifactorial. But even in infectious diseases, there are a lot of infectious diseases that can be considered multifactorial as well, right? So you may have a necessary agent, like you must have that particular virus or that particular bacteria, but you also have factors related to host susceptibility, right? And so in that sense, you can also look at it as a form of multifactorial disease. Although I would agree that most of the time, unifactorial diseases we consider mainly the infectious diseases or even occupational diseases, right? So in order to have lead poisoning, I must have been exposed to inorganic lead. In order to have noise-induced deafness, I must have exposure to loud noise, right? So you can almost say that a causal factor is a single event or a single condition that plays an essential role. Without that factor, you essentially have no disease. So there are diseases whereby you say that they are truly almost unifactorial, right? But most diseases are multifactorial, and I would like to depict this multifactorial as actually a series of pies, right? So these pies are sufficient causes, and each sufficient cause is actually a combination of factors. Okay? So I can get a disease like, say, prostate cancer or lung cancer, actually from different sufficient causes, right? But each of the sufficient cause is actually made up of several conditions or several events or several factors. Okay? And some of these factors are common across multiple sufficient causes. Some of these factors occur only through or act through only one sufficient cause. So I think if we have this as a model or as a concept for multifactorial diseases, you find that actually when we talk about multifactorial diseases, things are much more complex, right? And it fits into a lot of our examples of causation of diseases. Okay. Right? So if we are to tackle and to try and prevent a multifactorial disease, what should we be doing? If we have this model of sufficient causes and we want to tackle a multifactorial disease, what should we be doing?
Looking for the necessary cause, eliminate it.
So which one is the necessary cause? Are you referring to the alphabet, ABCD? Are those the necessary cause, or are we talking about the sufficient cause?
It looks like A and B are necessary causes in all of the combinations of causal signs, in which case the elimination of A or B would result in this never occurring.
Okay. So one approach is that we can just tackle what is common among all the sufficient causes. Right? So in this case, A and B are present in all the sufficient causes. Right? So if I tackle A or B, I can actually prevent the disease. Right? But unfortunately, things are never that simple. Right? Firstly, there are perhaps more than just 3 sufficient causes for occurrence of a disease. Right? So even if by tackling A or B, I may remove sufficient cause 1, sufficient cause 2, sufficient cause 3, there are other sufficient causes that could cause a disease. Right? That's one. Number 2, sufficient causes are adaptive. They are actually, the combination of sufficient cause is actually almost like a living organism. They adapt. They can evolve, they can transform. You remove A, right, from the 3 sufficient causes, the sufficient cause will evolve or adapt in such a way that now I can cause a disease without the presence of A. Something else may come in to substitute, or even if A is removed completely, B, C, D, and E on their own together can cause. Perhaps less efficiently, but they still can cause. Right? So it adds a totally different layer of complexity. That to tackle multifactorial disease is no longer a situation of finding what is the common denominator among the sufficient causes and then tackling them. And secondly, it's no longer a situation of just tackling a single sufficient cause. You think that sufficient cause is the most important. Right? So now the approach towards tackling diseases is that you really must understand as many of the causes as possible, as many of the sufficient causes as possible, and tackling them simultaneously. That's the difficulty. That's the problem. Right? Okay, so what factors need to be tackled to prevent multifactorial diseases? It's almost like we need to tackle all factors. And we need to tackle all factors at the same time. Because the combination of factors actually would evolve, they would actually adapt. Right? So to think of it as an adaptive system, as a complex system. So this is a map that has been shown many, many times. And the map is called an obesity map. And it demonstrates what are the factors that lead to obesity. Right? You find that a lot of all these factors are non-biological. They are things at the systems level. They are things at the organizational level. They are things at the societal level. Right? And they interact with each other. So it ranges from even like the supply of food and beverages to the ease or availability of food and beverages to design of urban communities. Right? So all these interact with each other, and all this can change. If we have a soda tax today, right, on say for example the sweet drinks, the companies that are producing those would change their marketing strategy. They will adapt to the tax structure. Right? The consumer will also adapt. And essentially, this whole thing is a living organism. So if you want to attack obesity, it should not be attacking obesity at one point. You have to study the whole thing as a system and then say, okay, I need to play with multiple levers. How do I deal with all these multiple levers? Right? So that's the complexity that we are talking about. That's why we need this whole area known as complexity science. Okay? So there's now this new field called complexity science. In the past, we basically say that let's not deal with complexity. In fact, we must try to simplify. Right? And for those who have done statistics, you do model building, modeling. You heard of this term called, I want to have the most parsimonious model. Right? The idea of a parsimonious model is that I want to have as simple a model as possible. If I can explain things with just two factors, let me try and explain things with two factors. Let's not add in the third factor, the fourth factor, or the fifth factor. Right? But essentially now we are saying that we cannot live with that kind of mindset. We need to change our mindset. But unfortunately for all of us who are trained in public health, we are still trained with a mindset of saying, let's try and keep things as simple as possible. Right? When we are presented with a complex problem, what do? We say, let's break up that complex problem into simpler components and then deal with one component after another component. Right? And we have the simplistic notion that if we answer all the simple components, then we put them together, we will solve the problem. Unfortunately, we are dealing with a living organism. Right? You break up the component into parts, right? And then after that you try and put it together, you find that it doesn't work. Right? You have to deal with the entire organism as one. And I think that's what complexity science is driving at. So we need to be able to now teach complexity science to public health people. Right? If you are just a researcher doing just physiological research or just doing basic research, yes, I think you need to have this reductionist kind of mindset and deal with things to say, let's try to simplify things. Right? But unfortunately now we are in the era whereby things are highly complex.
Hi, Prof. We have the PM here.
Hi, PM.
Hello.
Greetings from Singapore.
Hello. Greetings from Bandar Seri Begawan.
Wow. Fancy we have to meet each other through the internet.
Well, happy to attend your lecture. What are you discussing today?
Well, so we are discussing about the new public health. That the new public health has to deal with complexity. In this post-genomic era, we are beginning to appreciate that the causes of public health problems are highly complex. We cannot be tackling the issues one at a time. We have to deal with multiple levers. And the new public health students must start learning to deal with complexity science.
Do you have a regular discussion like this with UBD students?
Well, unfortunately, we should be having more of this kind of discussion, but actually, to be honest, this is probably the first or the second time that we're doing it.
Well, I'm happy that you're doing it.
Yes, we have been doing it with several other universities, but now we have one of our colleagues over at UBD for the next 2 to 3 years, and we have been trying to start this kind of session together.
Well, I'm happy that you are doing this with UBD because we learn from each other and then we can understand each other's circumstances. And in a complex world, what happens in one country can affect many other countries.
Yes, definitely. I think that the idea of these exchanges actually enrich the educational programs that each of us has.
How many students are in the classroom at your end? I have about 50 students here, not mine. And some audience.
I think I'm more popular in UBD than in NUS.
Please send my greetings to the students in Singapore.
Yes, I think you can see some of the students, sitting around. We're just within this conference hall, conference room here. Most of our lectures are actually in the night. So most of our students actually come to our classes at night because they are part-time students.
So today you are making a special arrangement for me?
Yes, exactly.
I hope not.
So this is a very special arrangement for you.
Thank you very much. I'm happy to have the chance to participate and to encourage you to do more. Thank you.
Thank you.
Thank you very much indeed.
We'll see you later, Prof.
All right. Okay.
All right. Okay. Yeah. In a minute.
Sure.
Hello.
Are you there? Prof Chia, are you there?
Yes.
Yes. Sorry for a little bit of delay. We have a good discussion and time with the PM.
Yeah, no problem.
Thank you for understanding.
Okay, shall we continue? Or shall we
Yes,
move?
please. Yes.
Okay, so I think the point I'm trying to make is that the point I'm trying to make is that we need to deal with complexity science, and we need to have at least some understanding of complexity science. I'm sure a lot of you know this guy. His name is Stephen Hawking. And I'm sure we would agree that Stephen Hawking is a very smart guy, definitely smarter than me, right? And he made this statement. He said, "I think the next century will be a century of complexity," and he made it in the year 2000. I have the cheap thrill of saying that Stephen Hawking is wrong. That for once I'm smarter than Stephen Hawking, right? That he's wrong. It's not the next century, it's the century of complexity. It's actually this century. We are already, in a stage of complexity. And if we don't deal with this complexity, then we're not going to be able to tackle a lot of the public health problems that we're facing. So we need to apply complexity science to health and then to our healthcare system as well. So the idea behind this complexity is that here this quotation says complexity is a description of the complex phenomenon demonstrated in systems characterized by non-linear, interactive components, continuous and discontinuous change with unpredictable outcomes. So complexity, I think, has a few issues there. One is that it is non-linear. Second thing is that it comes in a way that is unpredictable, at least with our current tools. In order to predict, we must start to think not in a linear fashion, right? We must start to think, instead of being along the line of machine, we must be thinking along the line of all these systems as organisms. So I think we need to shift in the way of our mindset and our thinking. Right? So the real world approach is actually having a lot of all these factors, a lot of them non-biological, and that all of them interact with each other in complex way, and they actually end up with a lot of outcomes, and a lot of outcomes interact with each other as well. Right? So we got to start learning to think in this way, in the form of very messy interactions, rather than simple linear kind of thinking. Right?
I'm just trying to see, how would you design experiments to
So the question that's asked by one of our friends here is that, how do you design experiments then? And so my argument I want to put forward is that the experimental design, or even the clinical trial design, is an old school design. Right? It's an old school design. It's too simplistic. Okay? We shouldn't be saying that.
You can ask.
Yeah, he's continuing. He was continuing.
Prof,
yes?
you have a question?
No.
Yeah, come on.
I was just wondering why they're old school designs. Why you call them old school?
Because they cannot answer real world problems. Let me give you a practical example. A practical example is you do a drug trial, right? So a randomized control trial is said to be the gold standard, correct? You conduct a randomized control trial. The end result of the randomized control trial is that in a controlled situation, drug A is better than drug B. That's all, right? And the aim is for the drug company to be able to get the FDA approval, and he can market the drug. Right? That's the aim. The aim is not whether the drug works in the real world. Right? To find that in a post-market survey, in phase 4 trial, you'll find that phase 4 trial usage of the drug, or the efficacy of the drug, is always much lower than RCT. RCT will produce results that says this drug is miraculous. In the real world situation, you find that this drug, well, it's still slightly better than the old drug. It is not a miracle drug. Right? And so the reason is because the RCT design is an experimental design where everything is controlled. Right? Even the selection of patients are controlled. Whereas in the real world out there, the drug is given to all kinds of patients, right? And through systems that are not perfect. And through situations whereby compliance is not the same as that of an RCT. Right? So that would be my argument for why the experimental design is actually an old school and old world design. Right? It simplifies things. You're trying to just make things as simple as possible so that you can conclude that, oh, the drug is the main factor. Right? And that's what the drug company wants. But if I'm a public health person, that's not what I want. As a public health person, I want to know whether it works in a real life situation or not. So the same thing with you do a mammography trial, right? you do a vaccination trial, the results are always so much better than what's in the real world. Right? Now that's what an academic can do, but if I'm a public health person, I want to know the results in the real world. So I think we need to change our mindset that there are many other factors that contribute to the effectiveness of a program. And we need to deal with all those factors at the same time. See? Okay, so let's go on to the last part, Public Health 1.0 to Public Health 3.0. So the first question is, how has housing, water supply, and general economic development contributed to the health of the population?
Question?
Yeah.
Oh.
That's the question. Okay, so I think we've got to appreciate that the improvement to public health, a lot of it actually came from outside the health sector. And in the past, when people are in rural communities and they become urbanized, a lot of the improvement in health was not because the doctors appeared. It was because there's now better water supply, there's now less overcrowding, and people could afford better nutrition and so forth. Right? Then secondly is, why are vaccination and tobacco control such effective measures in disease prevention?
Any ideas? Brunei? Number two. Number two.
Tobacco is very modifiable, like lifestyle factor that you can. I think it's one of the more modifiable lifestyle factor that you can change. Vaccination, I guess, it just stops the disease from occurring. So I think.
Yes. Any other view? Any other way of looking at it?
I think large number of people.
Yes, Brunei?
Yes, again.
I think, hello?
Yes.
I think another reason could be because of structural factors. People might want to change their lifestyle, but because the structures are not in place, sometimes they are put in difficulty of changing.
Yes. So a lot of times there are other factors that, especially for the third question, why is it difficult to control lifestyle diseases like diabetes? There are a lot of other factors and a lot of structural issues, that needs to be addressed. And for vaccination and say tobacco control, these are almost unifactorial kind of conditions. Right? Tobacco and lung cancer, for example, it can be almost considered as a unifactorial disease. Right? So you can just tackle one factor. Vaccination, you're protecting against a specific infectious agent. Right? So they are single factorial diseases. So my argument is that now we are dealing with diseases that are multifactorial. It is much more difficult to control these lifestyle diseases, which are multifactorial diseases. Right? So just a few examples to highlight some of the points that we were talking about earlier on. This is a chart. On the y-axis, it shows the mortality rate from tuberculosis. On the x-axis is the year. Right? And you find that actually mortality rates from tuberculosis have been coming down even before the tuberculous bacillus was identified, right? In microbiologically. And BCG vaccine, in terms of prevention of tuberculosis, came in very, very late. So why was the mortality rate of tuberculosis already coming down? Right? And it's because of primarily due to economic development, due to proper housing, less overcrowding. So the impact actually of all those non-health interventions was so much more compared to the health interventions here. The health interventions came in actually very, very late. Right? Same thing here. This is Singapore River when I was a kid. I actually grew up seeing Singapore River like this. Right? In the late 1950s, I love to go to Singapore River because of the food stores near Singapore River. But I hate to eat there because Singapore River was absolutely smelly. Absolutely filthy. All the hawkers along the banks of Singapore River will be preparing their food, and then basically all the leftovers thrown into the river. Right? So food poisoning is very common. So I grew up always having food poisoning. And when they clean up the river, when they control the hawkers, basically, they don't need to identify what's the causative agent for my food poisoning. Right? Food poisoning outbreaks basically were controlled just by cleaning up the rivers, making sure that there was proper water supply for the hawkers and so forth. Because if not, the hawkers will only have one pail of water throughout the whole day to wash all the dishes. So controlling of, and in the past we have all these hawkers going from house to house with one pail of water to clean all the utensils and all the glasses and bowls. Right? So it's very common to have food poisoning outbreaks from all this. So just by controlling it, it was very easy. Right? So I would like to argue that we have gone through different phases of public health. We have gone through public health 1.0, where the health of the population improved because of environmental improvement, because of economic improvement. Public health 2.0 was a time whereby we had single factor interventions like vaccinations, right? Like tobacco control. And that has done very well. I mean, our lung cancer rate in Singapore, for example, is coming down dramatically because of tobacco control. Right? So for so-called unifactorial diseases, single factor intervention works fine. But now we are in public health 3.0. We are dealing with multiple factors. We need to learn complexity science. We need to learn what's called implementation science. Right? Implementation science, the way I will illustrate this is, supposing you are learning how to play a piano, right? And you are in grade 1. I failed my grade 1 piano lessons, but I can still remember when I was doing grade 1 piano, I was playing the keys with one hand. And you're playing do, re, mi, fa, so, fa, mi, re, do, right? You're playing with one hand. That is simple kind of implementation. Now, if I had persevered and started learning more advanced kind of piano playing, you could start playing in chords, for example. Right? For those who know guitar, for example, you can play the chords on a piano. Right? And you now can play with two hands. And not only that, you handle the pedals at the same time. Right? Okay? And that is what implementation science is all about. Implementation science is how do you play with chords, and how do you make use of not just your hand, you make use of your legs as well. Right? You make use of the pedals. And then you actually get feedback, and to your ears and to how you feel, to what you're playing, and you play differently. And you respond and you adapt differently. Alright? And if you are really a pianist out there performing to an audience, a true pianist, you actually will interact with your audience. And I think that's implementation science. How to become a concert pianist. Right? Learning how to implement and having the interaction with the community that you're reaching out to. Right? So how do we move Public Health 3.0 forward? I think we need to focus on translating etiology into programs and policies. Right? From dealing with single to multiple interacting factors. So even if we are doing our etiological research, we shouldn't be saying, oh, let's try and simplify and look for the main factor. We should be looking for interactions, for effect modification. Right? We should be looking for more and more complex models rather than simple models. Okay? We should not go with the reductionist approach. Second thing is that we need to learn to deal with behavior. Okay? And a lot of implementation science has to deal with behavior. How will people respond to your implementation, to your program? Okay? So I think learning implementation science, learning behavioral science, learning the field of behavioral economics will be very, very important. And those are totally outside of our biomedical discipline. Our biomedical discipline is, okay, I still want to do the lab work, right? I found a SNP, I now want to do fine mapping to find, the causative gene, and so forth. So we need to do that plus going beyond. Right? And those are disciplines that are outside of of traditional biomedical science. And there were two recent articles in the journal Science where it highlights the importance of human behavior and highlights the idea of having a systems approach and a macroeconomic kind of perspective to control non-communicable disease or prevent non-communicable disease. So I think it highlighted this idea of implementation science. Give you an example of what we're doing in Singapore. So in Singapore, like in a lot of countries, when we look at the workplace, there's a lot of focus on safety issues, some focus on occupational diseases, very little focus on health issues like health promotion and general diseases. And this fragmentation and patchy focus occurs right across different levels, from the government level to the management of the company or the factory and down to the worker. Right? So what we are doing is to see whether we can come up with a total workplace safety and health system to integrate everything together. So it's a management system that we are after. Right? So if you are saying what is the key levers, the main common factor that you want to try and tackle, I would argue that yes, we are actually tackling the management level by trying to set a system in place, by trying to make sure that it's easy for people to look at this whole issue in an integrated fashion, right? By providing, for example, modular kind of health protection, health promotion programs, by focusing on capacity building and working at sustainability, making it easy to have this management system in place, making it easy for both the workers and as well as the management to look at things as an integrated thing. Okay? So this is one example of looking at things from systems level, looking at things in an integrated fashion, and looking at issues of implementation. Okay? So early on the question was, how do you design an experiment? And I would argue that instead of designing an experiment, now we conduct in silico experiments. Okay? So in other words, we run simulations. And when you run simulations, I can play with multiple factors. I don't need to create an experimental design whereby I control everything else and I just deal with one factor. Right now with complex simulation and modeling, I can then actually play with multiple factors and then use that to help in terms of program and policy implementation. Okay? Because after all, when you conduct an experiment, intervention trial and so forth, what's the purpose? You're trying to use that to help you to make decisions. Okay? And then you find that in order to make the decision, your experimental design only answer one question. To make my decision, I have 10 questions that need to be answered. Right? So can I deal with 10 factors together? Right? My argument is yes, you can. You can do it in silico. You find that it's unethical to do it in human population, but I can run it in silico. Right? And that's what essentially we're doing, whereby we have this population health metrics and analytics that we're developing within this School of Public Health. We have a modeling and simulation course. Right? But this modeling and simulation needs data. The simulation is as good as the data that you have. Right? But actually there are a lot of good data out there. Right? It's just that it's not organized properly. So one of the jobs that we're trying to do is to set up a data repository to organize this data. Right? And then sometimes the data is not really available out there. We need to collect new data. Right? So we have this cohort of 50,000 Singaporeans whereby we can go out to actually collect new data. Right? So we ran this simulation, and this simulation essentially were able to predict the prevalence of diabetes in Singapore in the year 2050. In the past, we will predict it just by using age, sex, and ethnicity. Now we can add in genetic factors, we can add in the trend in obesity. If we just use the traditional method, the old method of just using age, sex, and race, we predict that we will have 13% of our population as being obese. Right? But if we add in the other factors, it is actually 15%. Right? And because we run this in the form of an agent-based kind of simulation, we can actually construct the population pyramid. And this is 2010 in Singapore. The black part represents a proportion who are diabetic. Right? So, in comparison, you look at it, it still looks pretty small, 11.3%. In 2050, this will be our Singapore population, and this will be the proportion of diabetics. So the population pyramid will look like an apple, and that apple will be rotten to the core. We will have a rotten apple of diabetics in Singapore. We will have 1 million diabetics by the time of 2050. I wish the PM was there now.
You should tell that earlier. Where is the PM?
I think the other point about Public Health 3.0 is the idea of moving back to focusing on primary prevention. So if you remember in your public health lecture, in epidemiology lecture, there's a difference between primary prevention, secondary prevention, and tertiary prevention. A lot of times, secondary prevention and tertiary prevention is actually in the clinical medicine domain. It is not in the public health domain. Right? Secondary prevention and tertiary prevention happens in primary, secondary, and tertiary healthcare settings. And a lot of doctors now, they say, okay, we need to go into primary prevention. And they get confused between primary prevention and primary healthcare. And they think that by focusing on primary healthcare, they are doing primary prevention. Right? Primary healthcare actually deals mainly with tertiary prevention, and for some situations, some secondary prevention. Primary prevention actually occurs primarily outside of non-healthcare settings. Right? And there's a danger that public health trained people actually get sucked into the clinical medicine arena to be doing secondary prevention and tertiary prevention. I think we've got to resist that. We've got to make sure that our focus is actually in primary prevention. So to me, Public Health 3.0 is actually back to focusing on primary prevention. It's almost like back to Public Health 1.0, right? Because in Public Health 1.0, we really were doing primary prevention, right? By preventing social overcrowding, by preventing, bad water supply, by providing with good sewerage control, everything, that is actually primary prevention, right? So actually, we need to go back to focusing on primary prevention. Just that now the primary prevention is much more complicated. We need to embrace complexity science. We need to embrace implementation science. So I think in summary, what I try to highlight is that we want to now look at how do we maximize actually the public health impact of genomics. I think genomics is a great thing, but how do we now draw the gems and the jewels out of the genomics revolution? And for us in public health, is we need to go into to find the public health impact of genomics by going beyond the genome and look at gene-environment interaction, beyond bench to bedside, and actually go to the population, beyond just discovery, go into programs and policies. Okay? So I think we need to do that. We need to change our mindset. We cannot be stuck with our old mindset of being very linear, of being very reductionist. Right? We need to embrace complexity. And we need to be innovative through integration. Right? We need to integrate all the different factors, all the different stakeholders, right? And come up with innovative ways of how do you integrate them. And then we need new tools. And I want to propose that simulations and scenario planning is one of the new tools that we can use. Okay? There will probably be newer tools, and I hope Public Health 3.1, 3.2, 3.3, will come up with newer versions and newer tools. All right, I'll end here, and if there are any questions or any other points that anyone wants to raise, please feel free to do that. Any questions or any views?
Any questions?
Yes, I would like to ask you a question.
Yes?
But let me just first of all say thanks to you for your presentation. With no iota of doubt, we know that public health has made significant achievements in the world by preventing ill health, prolonging life, and promoting population health. But that achievement has also been superseded by an epidemiological transition to non-communicable diseases, which have become a global burden. And worst of all, we notice that health protection and health promotion have been divorced. Health protection is more or less practiced within a legal framework, wherein, health promotion is not. If you are talking about returning to our roots, that's to practice primary health care or primary prevention, what strategies are we going to implement to ensure that health protection and health promotion is merged, in promoting workplace health?
Yeah, so that's what we've been trying to do. I mean, you are perfectly right. Health protection is primarily through legislation, and health promotion is primarily through advisory. Yeah? So if I am the employer, of course I'll focus more in terms of obeying the letter of the law. Right? But I think we must firstly take a higher view. Right? The aim of public health is actually towards changing people's behavior. Right? And that includes changing employers' behavior. Right? That we should actually develop a culture both in our employers as well as in the employees to see that health protection and health promotion are good for me, and that they are intrinsic, almost like intrinsic rights that I should be expecting firstly from myself and then also expecting from people around me, right? That they must have that culture of helping me to protect myself and helping me to promote my health, right? So I think we should take one step higher and say that we should be actually promoting that behavior change and developing that culture within our society. Okay. So if we take that view, then you will have to agree that legislation is only a tool towards that. Legislation will never be able to bring me towards that culture. Right? It will need more than legislation. It will need many other factors to come into play. Right? So that's one approach whereby people are saying that in order to merge health protection and health promotion together, we must legislate health promotion. Right? We must be tough. Employers will only respond to the rod. Right? So we must legislate that if your company don't provide health promotion, it is as bad as not providing health protection. I don't think that's the right approach. I think it should be trying to promote that culture in both the employees and the employers, and use legislation as only one of the tools and try to use many different tools. Right? Sometimes it may be economic incentives that are needed, right, to help companies to jumpstart into this. Sometimes it may be through incentives like rewards. Right? And I think above all is to how do you communicate to employers that actually health protection and health promotion are good for business. We need to actually create a business model that both health protection and health promotion are actually good for business. And one of the reasons why right now we don't have a good business model for health, even health protection, we may not have a good business model. The reason is because we don't know how to measure costs properly, we don't know how to measure benefit properly. Right? And a lot of prevention measures, we find that we're unable to find a business case for prevention is because we don't know how to measure the impact of all this. So if we can come up with tools to be able to measure it well, I think we can actually make a very strong business case for prevention. Yeah, it would be very interesting, for example, to say what's the economic impact of cleaning up Singapore River. Right? Nobody has actually done that calculation. Yeah. If someone could go and do a calculation of what was the cost of cleaning up Singapore River and keeping Singapore River clean, right? And then what was the subsequent economic impact? I think it will be a very interesting exercise, and I think they will find that it's probably a very cost-effective exercise. So some of these things we take for granted. We take for granted that fluoridation of water is cost-effective. We take for granted that providing clean water supply is cost-effective. Yeah? But I think, if we have someone who is interested in economics and someone who is interested in history at the same time, if you go and do a project on actually calculating what the cost effectiveness of all this so-called prevention that has been done. Yes.
How do you deal with the different philosophies with different governments?
Okay, that's a very good question here. That how do you deal with different philosophies of the governance, of different governments, and not many countries are like Brunei and Singapore where we have stability, in terms of the government. And I must say that that's actually, I would say that actually is one huge advantage, right, that we have. But the reason whereby we can progress in terms of our public health with such great pace in both our countries because of stable government is that this whole development was a top-down movement. Our governments know what is best for us, right? And they did what they think is best for us, and yes, the health of the population improves. But I think we're increasingly recognizing that there is another sector, right? That the people, the civic societies and the people can actually know what is good for them. And they can actually initiate a lot of things, right? So in Singapore context, at least we are beginning to appreciate that only quite recently, because we have been living under a system whereby they have taken care of us. We don't need to really take care of ourselves. So that part has been underdeveloped, right? Okay? We have developed, in fact, a dependency kind of syndrome. And now then we are learning to become, independent and self-dependent. Right? But in a lot of other societies where they do not have this advantage of a stable government, a lot of local communities have actually ensured that there is good public health at the local level and good governance at the local level. So in a sense, we mustn't underplay that. And I think in a lot of global health kind of activities and projects, you'll find that is what you are tapping on. Because in a lot of those communities, the infrastructure is not there. You are tapping on the energies of the community, right? And making things happen from the ground up. So I think I agree with you. We had it easy, right? Because we have a stable government, but that is not necessarily the only model. There have been good public health in a lot of situations whereby there have been poor central government.
Well, it's approaching 5 o'clock. Shall we call it a day?
Let me check with the group if they have any questions.
May I ask you one more question?
Sure.
How's that, Prof? Yeah.
Because health protection and health promotion have been separated, we tend to realize that health promotion is a bit behind. So what should we do in the case of building the capacity and sustaining health promotion? Because I can see some problems with capacity building and sustainability. What should we do?
Yeah, I think definitely health promotion, I agree that it has been kind of left behind when you compare it with health protection. And I think we need to develop health promotion more, but I think we need to change our model in terms of health promotion. We need to demedicalize it. There's too much medical influence, in health promotion. And that coming from a doctor is heretical.
Very painful.
Yeah, it's even, you can't see very clearly, there are tears in my eyes.
Of course.
So I think the leadership in terms of health promotion possibly will have to be from a non-medical sector. It has to come from, I think, a behavioral science angle, and possibly, I think in this day and age, possibly from a behavioral economic kind of angle. To not try to use the traditional medical model towards health promotion, whereby we say that there are certain biological facts that are indisputable. Smoking will cause ADAPT reform within the DNA, and this will cause mutation in your cells and cause lung cancer at the end of the day, and to try and say that this should frighten you out of your wits, and therefore you should change your behavior. So that's a very medical way of thinking. I think we need to take a totally different approach in that. So I think firstly a change in mindset, and I think secondly to actually teach this whole subject totally differently from the usual way that we have been teaching health promotion. So I think we need to get our own house in order first before we can actually say that, hey, health promotion must be elevated to a higher level, higher status, because the danger is that we can get the political support and everything to elevate health promotion. Once you elevate it, you are in public view. You are in the view of also all the other medical community, all the other professional community. And if they see that there is no substance in it, if they see that what is being elevated is nothing, right? It's just talk, then you lose all credibility. So I think we need to rethink, what is health promotion in this new day and age? What kind of research can we be doing that can be showcased as almost like a poster boy? Then I think we'll be ready to say, okay, let's get the support from the politicians to showcase it. So that's the reason why we embarked on this Total Workplace Safety and Health project, because we think that we can actually use that as example to try and put health promotion in its right place, so to speak, right? So we're doing a lot of pilot projects and so forth, and then after that it becomes a poster boy, and from there we can push it forward. I hope I made sense.
Yeah.
Yes, thank you.
Nice.
Okay, thank you very much for joining us. And
Yes, we have a great time, Prof, listening to your idea. And thank you so much for understanding the situation with the PM earlier.
no problem. And I hope we can have more of such sessions in the future.
Yes, for sure. Yeah, we'll speak to Prof David, see if we can arrange more of this.
Okay, great.
Yeah.
All right, thank you. Bye-bye.
Bye. Have a good evening.